Sherry, and hello everybody, and thank you for joining today. I'm just going to give you a couple of little pieces of information before we pass you over to Dr. Elwood for today's session. If I just move the slides on. So the first thing is instructions for CE credits. As Sherry just said at the top of the hour, these were sent in an email to you with the attachments. For ASHA CE credits, I'm going to mention our other awarding bodies in a second, but for ASHA, you need to complete the attendance sheet if there's more than one of you attending. You need to complete the participant form and the evaluation form and return these no later than July 25th to Darlene Davis, and the instructions are on your screen right now. You will have a handout as well, and these instructions are on the handout that you received at the top of the hour also. I'm not going to read all this out word for word, but rest assured all the information is there, and the links are in the email that was sent to you at the top of the hour. For AOTA, NASP and APA, again, you need to complete the sheet and the evaluation form and email those by no later than July 27th, and again to Darlene Davis, and the details again are on your screen for this. So these were all sent to you at the top of the hour as well. So I'm going to skip on quickly from that and do a quick introduction of our presenter today. Dr. Glenn Elwood is a Professor Emeritus of Pediatrics and Psychiatry at Southern Illinois University School of Medicine. Southern Illinois University School of Medicine, and served as Chief of the Division of Developmental and Behavioral Pediatrics and Psychology for many years. He is a fellow of no less than 6 divisions of the American Psychological Association and is board certified in clinical psychology and clinical child and adolescent psychology. He has served on numerous committees and executive boards with APA, the Society for Developmental and Behavioral Pediatrics, and the American Academy for Cerebral Palsy and Developmental Medicine. Dr. Elwood is a past president of the Society of Pediatric Psychology, which is Division 54 of APA, and the Society for Developmental and Behavioral Pediatrics. He also served on the board of directors for the American Academy for Cerebral Palsy and Developmental Medicine, and has been associate editor of the Journal of Developmental and Behavioral Pediatrics since 2003. Dr. Elwood has authored more than 100 peer-reviewed papers, chapters, abstracts, and reviews, including the new Bayley-4 and the Bayley-4 screening test. And on that note, I will pass you on to Dr. Elwood. Please place any questions in the chat box. Myself and a colleague, Dr. Gloria McCoo, will be responding to some of those questions, and we'll have a short Q&A session at the end as well. So I will pass you on to Dr. Elwood.
Good morning. I guess it's afternoon for some of you, and early morning for others. Nonetheless, I appreciate you being here today. One of the big questions that we're faced with at this time is, how does the Bayley-4 compare to the Bayley-3? This has clinical and research implications, and it's going to have ramifications in terms of longitudinal follow-up or clinical reevaluation. In this webinar, I'm going to present similarities and differences between the two assessments, and present reliability and validity issues, and realize that in terms of developmental assessment, there are 3 components: the administration of structured test items, direct observation of typical and atypical behaviors, and active participation of the parent and caregiver. It is a complex process, and one that should not be taken lightly. Here's the disclosure. As Shelley had said, I am the author and will receive royalties for the test. That gives you an idea why I'm doing this today as well. Here's the agenda, and I'm going to try to stick to this as much as possible, but realize that there are overlapping issues in each of these segments, and so it's not going to be as separated as it looks here. Okay, the objectives are pretty straightforward. I wanted to describe the differences and similarities. I wanted to describe how the two versions differ clinically so that you can apply this knowledge to developmental testing. And I want to also discuss the basis for changes from the Bayley-III to the Bayley-4. Skipped one there. Okay, let's talk about the differences first. First of all, the Bayley-4 has what we call polytomous scoring. What that means is that there are now a 0, 1, and 2 score versus the dichotomous 0, 1 of all previous versions. I believe with the 0, 1, we miss subtle differences. There's no doubt that there's a difference between a child who can show success on a task and one who does not. But what about the child who is somewhere in between? This is different, and it is an emerging skill. Emerging skills may indicate delays, whereas absence would indicate the possibility of a more serious developmental deficit. Let's take jumping off the floor, for example. A 0 score would be a child who does not attempt to jump off the floor with both feet leaving the surface, or the child who has his feet essentially glued to the floor. A score of 1 would be the child who can lift maybe one leg off the floor but still uses the other foot for support, whereas the 2 option would be jumping off the floor with both feet leaving the surface simultaneously. Another thing that's different is that we are including caregiver report and much more caregiver participation. Caregiver report is now included in 56 items with expressive communication, receptive communication, and gross motor areas being the most dependent on caregiver report. Now, with the caregiver report, there are several items that only use this, not as an auxiliary way of scoring. These would include such things as imaginative play or relational play. Now, you might say caregiver report is kind of a soft way to administer a test, but we put a lot of effort into this so that the questions are administered in a standardized manner. They are specific, and a 2 response will be almost all the time, every time, or greater than 75% of the time. A 1 response would be some of the time or occasionally, whereas a 0 response would be none or absent or not present. Now, when we looked at the differences between administered items and parent or caregiver report, the differences were insignificant, and so they are included. Let me give you an example. And this actually, the caregiver report came from my work with the Bayley Infant Neurodevelopmental Screener, because we only had 11 to 13 items per age group. And if the child did not answer, we would be up a creek, so to speak. So that's one of the reasons that I felt the caregiver report would be helpful. So here's a good example. When you read Susie a book, does she pay attention to the entire story? And a caregiver could say almost every time, some of the time, occasionally, or none of the time. So you get an idea of how to do this. Some of the other caregiver report items incorporate examples that the caregiver has to generate. So it is a useful tool. The normative sample is a little bit different than the Bayley-III, because the Bayley-III had 10% seeded clinical cases. As you're going to see in a little bit, that's not as big of a deal as we thought it was when we did further analysis. The clinical samples are more strictly defined. We had 9 clinical samples for a total of 412 children. And I have a slide on that I will show subsequently as well. The adaptive behavior scale is different than the Bayley-III because we use 120 items from the Vineland-III that are applicable to the age range of the Bayley-IV, and I will describe that subsequently as well. There are going to be norms and validation studies for other countries as well, and Australia is undergoing their own normative data, whereas the UK is undergoing or will be undergoing a validation study. Now, I did skip over the B4 Q Global because that is a really slick program. It is used on iPads, laptops, regular computers, and that will be discussed, I believe, in a webinar on the 23rd of this month. So I'm not going to spend a lot of time, but I encourage you to look this over because it cuts down the time required. It cuts down the error possibilities, and so on. There are fewer items on the Bayley-IV. The reason I did that is I wanted to combine them. And basically, let's look at the mirror item, for example. Instead of saying one item would be the child interacts with the mirror, the other one would be a child approaches the mirror. That was in the Bayley-III. I combined them so that the child would approach would be a 1, a 2 would be interacts, whereas a 0 would be does not do anything with the mirror. And the caregiver report was used in norms, by the way. Now, similarities are that there are 5 scales, just like the Bayley-III. They continue to have growth scores, although there are no charts as was found in the Bayley-III, probably because it is not used as much as we thought it would be. And the social emotional scale, which is Greenspan's, was renormed on 320 children. Now, some other differences is I really worked hard, well, we all worked hard, to simplify the administration. And that's why the Q Global is such a innovative program. I wanted to reduce redundancy. In other words, if a child can do one task, why keep assessing that same skill over and over again? So what we did, if the items correlated 0.80 or better, or higher rather, we kept one and got rid of the other. I was also very keen on reducing items at the upper end of the ability scale. And, this test is used to assess or identify children who are at risk for developmental delay so that we can get intervention programs started. I'm really not that worried about the child who's going to a preschool, which is a feeder school at Harvard, and they just need to get a measure of the child's development. This is a test that is used to help the children who need it the most. So as a result, I reduced the items at the upper end of ability, and I added more at the lower end. I also added neurodevelopmental items, such as an asymmetric tonic neck reflex, parachute reactions, things of this nature, because development goes from the neurologic to the motor to the cognitive. And these early neurodevelopmental items give you an indication of the ability of the brain to exhibit more primitive responses. I also wanted to monitor the item gradients. Item gradients basically mean a small increase in raw scores should translate to a major change in standard scores, and we didn't want that. Now, I want to talk about validity a bit. First, tests per se are not valid or invalid. Rather, it's the test scores are valid or invalid for making specific interpretations. And two of the primary ways I'm going to discuss today to determine validity involve comparing the test to extant measures and comparing normative group data to specified clinical groups. So let's talk about score comparisons first. As you're aware, we have the Bayley, the Bayley-II, the Bayley-III, and now the Bayley-4. Now, interestingly, between the Bayley-II and, the Bayley and the Bayley-II, the mental developmental index decreased by 12 points, and the psychomotor developmental index decreased by 7 points. People said this was due to the Flynn effect. Well, it may have been due to other things, particularly the basal and ceiling scores, because with the Bayley scale, the MDI, you had to have 10 items in a row to have a basal score, 10 items passed, and 10 items failed to have a ceiling score. For the PDI, it was 6 points both ways. Now, when you come over to the Bayley-II, the item sets were age-based. And what that means is that there was a certain number of items that were administered to the child. And out of that set of items, you had to have 5 passed and 4 failed. If that were the case, you would stop the testing, even if the child scored on some higher items. These would not be included. So this was an issue, and there was more of a problem in the sense that the examiner could decide pretty much without much guidance as to where to start. And this actually sounds weird, but it actually lowered the score in preterms who were corrected because they were moved down in terms of item set, and they were not given credit automatically for the ones before. Whereas if you're a full term, you would get credit if you passed 4 of the items in the item set. Now, when we went to the Bayley-III, things got a little more complicated because the Bayley-III showed an increase. Now, why? Well, I think there's several reasons. One, we went back to a different way of looking at basal and ceiling scores. So we didn't have this item set issue that we have for Bayley-II. Number 2 is we had to separate out the MDI into language and cognitives and the PDI into gross motor and fine motor skills, that had an impact. Whether the, whether the seeding of the 10% of clinical cases had an effect or not will be shown, will be addressed in this next slide. But I do want to indicate that the Flynn effect on the Bayley is 3.4 points cognitively per decade and 2.49 points motorically per decade. Interestingly, in Australia, it's higher, 5.8 points. Now here's what we did in the Bayley-III is we looked at the cognitive, language, and motor composites with and without the clinical cases. And as you can see, it's about a 1-point difference. So this is not the major issue. So let's look at the score comparisons between the Bayley-III and the Bayley-4. We had 184 children, and they were counterbalanced, so some got the Bayley-III first, some got the Bayley-4 first. And basically here, remember, the start points are you get 2-point responses on the first 3, that's your basal, and you get 0 points on 5, and that's your ceiling. And we have start points on the Bayley-4, and these are gauged by where 95% of the children at that child's age would get a 2. Similarly, the 5-point ceiling was determined because the likelihood of getting any further points was less than 0.5. So this seems to be a better way to proceed in terms of starting and stopping the test. And as you can see, the cognitive, I translated the cognitive scale score to a composite score, and it's got 103 on the Bayley-III and 102 on the Bayley-4. The language scale composite, 102.4 on the Bayley-III and 101.9 on the Bayley-4. Finally, the motor is 102.3 and 101.0. So establishing a scale's validity is dependent on comparing it to extant tests. And obviously the Bayley-III is one such test. Now we also compared it to the WIPSI-4, which is kind of the gold standard for cognitive abilities in young children. And there were 104 children involved in the Bayley-4, WIPSI-4 comparisons. The cognitive Bayley score in this group was 99. I extrapolated once again the scale score to the standard, the composite score, whereas on the WIPSI-4, the full scale IQ was 103. The Bayley-4 language composite was 100.6, where the verbal comprehension index on the WIPSI-4 was 103. And finally, the cognitive, again, was 99, and visual spatial index was 100.2. So what you can see here is that these are quite comparable. We also looked at the motor comparisons to the Peabody Developmental Motor Scale 2. Gross motor scale score on the Bayley-4 is 9.9, and that's pretty close, once again, to 100, whereas the Peabody gross motor score was 101.1. The fine motor scale score on the Bayley-4 was 9.9, whereas on the Peabody, it was 97.5. And the thing that really blew me away was that the motor scale on the Bayley-4 was 99.5, as was the total motor scale score on the Peabody. Intercorrelations. This gives you evidence of convergent and discriminant validity. And as you can see, the test hangs together pretty well. Obviously, gross motor and fine motor are not going to correlate highly with expressive communication or receptive communication, but the cognitive and receptive communication and expressive do hang together. So this is validity based on internal structure. Split half reliabilities, where you take half the items and you correlate them with the other half at each of 17 ages. This is the composite of the correlations, and you can see they are quite good. So once again, the test hangs together nicely. Standard error of measurement and test-retest correlations. I'll let you look at this, but basically, it seems like the Bayley-4 is a slight bit more tight, I guess is the best way to describe it, with the standard error of measurement, which is the third column. It says Bayley-4, cognitive 0.89, and so on. The test-retest correlations, I believe the average was less than 9 days. Once again, counterbalanced. And you can see that the test-retest estimates are quite good as well. We also looked at the standard error of measurement on the clinical groups and the test-retest correlations. And as you can see, the test has integrity even with the clinical groups, which oftentimes bring more variability into the situation. So this is a good indicator as well. Now, I mentioned earlier that the adaptive behavior scale now comes from the Bayley-III. There are 120 items. The receptive and expressive scales comprise the communication scale. The personal scale is the daily living scale. And play and leisure and interpersonal relations are the socialization scale. And obviously there is a communication scale as well. So as you can see here, you get a well-rounded view of the child's skills. Now realize that with this test, we are looking at what the child typically does, not necessarily what they can do. Now, many of you probably recall the growth scale values. Now, many people have never used this, and quite frankly, I've not used it very much in the past. There's less emphasis on the Bayley-4 than in the Bayley-III. And there are no pages of graphs now, which are like a growth chart. It is a metric that does not involve age-based comparisons. So it's useful for tracking an individual child's progress over time. As raw scores increase with repeated administration, the growth scale values increase, and there's relative growth over time. It is essentially a linear transformation of the score using the Roche-model method and item response theory. It's an equal interval scale. The mean is 500, the standard deviation is 100, and the range goes from 200 to 800. It helps you to determine an ability estimate independent of peers because the child is measured against himself or herself versus a peer group. This is good if you have just minor improvements in a child, for example, who has significant neurodevelopmental problems, because improvement might not show up in the Bayley-IV scales, but would show up as an increase in the growth scale value. Now, this is a big issue, the test duration times, because it was estimated that for 13 months on the Bayley-III, it took 90 minutes, which is a long time for the examiner and for the child. I have not run into very many children who will attend at 13 months of age who will attend for 90 minutes. And we don't all have the luxury of sending them to lunch or letting them have a nap and then testing them again. So what we have here is I'm going to present the 50th percentile in terms of times, and this was obtained by the Q Global administration, which is faster. Now, there are several things that will slow down these test duration times that you're going to see. The first is a learning curve. The learning curve is very rapid utilizing the Q Global program, but still it takes time to learn. In addition, because we're standardizing the tests, all scoring options had to be done in an exhaustive fashion. So in other words, if they only had to name 5 pictures, we keep presenting the other pictures just to see what the normative data would look like. We also administered both caregiver report and administered observed tasks. So that, again, would increase the time. So here are the different times. In the normative group from 0 to 12 months, the mean time was for the 50th percentile was 35 minutes for all 5 of the administered scales. For 13 to 24 months, it was 63 minutes. Remember, I told you that 13 months it was 90 minutes before. So we've reduced this by a third. The normative group from 26 to 42 months, 68 minutes. So we're talking about an hour for 13 months and above, which is a significant decrease in comparison to previous time allotments necessary for testing. Now, children with Down syndrome took, and the average age, by the way, was 20.3 months, 69 minutes. Children with autism spectrum disorder, the average age was 36 months, took 71 minutes. And those of you who test children with autism spectrum disorder understand that it often takes longer with children with this disorder for a variety of reasons. Language delay and specific language impairment are 2 different things, and I will be describing that in the next webinar. But the average age for the language delay was younger than the specific language impairment, because the specific language impairment doesn't become apparent until later. It took 67 and 62 minutes. Children with developmental delays, 53 minutes. Motor impairment, 56 minutes. The child with prenatal drug and alcohol exposure, 55 minutes. Moderate or late preterms, 63 minutes. Moderate or late, or 32 to 36 weeks, gestational age. The extreme or very preterm, you can't see there, I'm sorry, it's very preterm, is 57 minutes. These children are less than 32 weeks. So these are rough estimates, and quite frankly, I think with familiarization with the program, these could be cut down by another 10 or 15%. Now here are the 9 clinical groups, and to show the validity of the Bayley-IV, every clinical group scored below their matched comparison group across the board. So let's look at Down syndrome first. We have 54 children, and there was a 33 to 35 point decrease in terms of comparison to the controls for cognitive, language, and motor skills. This is what we would have expected because we expect global developmental delays. With autism spectrum disorder, we had 31 children. And as you can see, the scores were anywhere from 23.5 to 35 points less than the comparison group that was matched once again. Also, language was the lowest score, which you would expect. The language delay group showed anywhere from 12 to 27 points below their matched comparison peers, and language was a major area of deficit. The same with the specific language impairment, roughly 15 to 20 points below their matched peers, and cognitive was low average, but you wouldn't want it in one of the criteria for specific language impairment is that the cognitive abilities should not be it should not be impaired. So here we have them in the low average range. Developmental delay, 15 to 18 points below peers. Pretty straightforward there. The motor impairment group is an interesting group because we did not take the severe cerebral palsy group in this. We had mild to moderate cerebral palsy as well as a developmental coordination delay diagnosis. And we had 40 children that met those criteria. And as you can see, their scores essentially were borderline. The moderate to late preterm scores, there were 70 children here, scores in the average to low average range, which is interesting. However, they still were significantly below the matched controls. Nonetheless, they are not nearly as low as the very or extremely preterm children, whose scores are greater than a standard deviation below average and ranged from almost 15 to 20 points below their peers, their control peers. And finally, we have the prenatal drug and alcohol exposure, 44 children. And their scores are, once again, low average to borderline, whereas the controls are in the average range. and the deficits range from 16 points roughly to 25 points. And to summarize, well, there's strong evidence to support the validity and reliability of the Bayley-IV. Interestingly, it's the first edition that is actually comparable to the previous one. Now, even though the Bayley and Bayley-II had MDIs and PDIs, there were differences in terms of, as I said before, the administration, the basal and ceiling scores, and they did add more items from the literature, not necessarily from the Bayley's orientation. The clinical group data, the WIPC-4 data, and the Peabody Developmental Motor Scale data all underscore the good psychometric qualities and validity of the Bayley-IV. And I want to emphasize that this is a high-stakes issue. I think Pearson is quite aware of this, and it's imperative that we get it right, and I think we do. And with that, I guess we open it up to questions.
Yes, hi there, Glenn. Thank you very much for that. It was very interesting. So if people want to put any questions in the chat box, I have a couple that have come up. Number one is, has the picture of the telephone been removed as it's outdated and many kids have never seen one? I can answer that, but I didn't know if you wanted to answer that one, Glenn.
Was the telephone, is what you said?
Yeah, the telephone picture's been removed. I mean, we have removed outdated items, so things like telephones have been removed from stimulus materials.
Yeah, basically, most of the artwork has been done in contemporary norms or more, you know. So, yeah, an old-time telephone is something that most children would never have seen before. So I think we took all of those kind of considerations when we came up with the new artwork.
Excellent, thank you. Okay, another question, and I think this goes back to slide 23 of yours, and it's about the asterisk against the ages. We have a question just asking what the asterisk is referring to, and I wasn't sure on the answer to that.
The asterisks are the mean ages of that particular clinical group.
Excellent. Thank you very much. Okay, and then another one, and I'm not quite sure on this question. It's, what is the best test for a 24-week preterm infant? I don't know if that's one you're able to answer.
What is the best test for the 24-week preterm infants? Some of it depends on the child's corrected age when we test them. Give you a little idea, I'm looking at that right now, and it looks like the 24-weekers still need correction at 3 years of age. Because we have the neurodevelopmental items here, and because probably 95% of those children who are born at 24 weeks have some type of neurodevelopmental issue, I think the Bayley-IV would be appropriate. Once again, a lot depends on the age. I would not put much faith in any test that would test these children probably before 3 months of age, because they're still trying to, stabilize. So I don't know if I've answered that question or not.
I think if not, we'll see another question come up in the chat box, so I'll mark it as answered for now. I'm just going to answer a couple quickly. One question is, can we see an example of the Bayley-IV being performed? We have on the Bayley-IV program page on the website, we do have some videos and there is one video demonstrating the Bayley-IV being performed and using the digital administration. And we also have a detailed video of the digital administration as well. So yeah, you'll be able to find that on the website. And then another question which I will answer is, when is the planned release date? Planned release date is the middle of September. We have pre-publication pricing available through to the end of September. At the moment, it's looking like it will be September 12th, and we're pretty confident that that will be the date. So, but I'm saying sometimes it moves a day or so either side, but around about September 12th.
Can I also add something? We also are going to have a Bayley screener, a Bayley-IV screening test. And that is going to be released not too far after the regular Bayley. Am I correct on that?
Yes, thanks for mentioning that, Glenn. Yeah, it's available. That will be right at the end of November, but it's because it's the last week with all the holidays, we're saying the beginning of December, just to be sure on that one.
Mm-hmm.
Okay, another question. What specific test items are different? Now, that is a difficult question to answer on here. I can sort of give a summary and then ask Dr. Elwood if he has anything else to add. But we have reduced the number of items. There are some summaries on the website regarding the number of items. So one of the big differences that Dr. Elwood has mentioned is the adaptive behaviour items have reduced from 241 to 120 items. So there's a big change there. And then there have been some changes amongst the subtests, a general reduction in the number of items. Some of the and some items have been adjusted and updated, but I don't know, Dr. Elwood, if you have anything else to add on that. It's difficult to answer in here, but we're trying to provide that information to customers.
Yeah, I think you've hit the major points. We've combined items and we've eliminated redundancy, which is going to reduce. For example, if they could build a certain structure with blocks and another building of a structure with blocks is correlated 0.80 with the first, I don't know why we necessarily have to do the second one, except that it would increase reliability, but it also would increase test time. So we had a goal of reducing the amount of time necessary, because I think even though you might have a more reliable test with more items, the validity of the test, meaning was this really a true measure of development, will be reduced because the child would have fatigue, hunger, and so on, and probably the examiner would as well.
Excellent, thank you. Another one, and I can answer this one, are the materials more sturdy and able to be cleaned per Joint Commission hospital regulations? We have updated some of the materials. If you have specific questions about items, then it might be better to speak with us directly on knowing what materials are all in those, but they are all safety tested, and we do provide instructions on keeping them, on cleaning and retaining and maintaining the items. So again, it's a difficult one to answer all the specifics. Some items have remained the same, some have been updated, some, obviously are no longer being used. So, but we can speak with you directly about that if you have more questions on it. Another one for you, Dr. Elwood, is, are the ages of the tests the same, topping out at 42 months?
Yes. 16 days to
Yep.
42 months.
Excellent, thank you. I'm just flagging these as answered. Okay. And this one, is there any research or plan to compare the Bayley-IV with the preschool language scale For many of our 2-year-old children, we see very different scores between the Bayley-III and the PLS, or the preschool language scale. I know we do report the Bayley-III and the PLS study in the manual, but I don't know if you have anything else to add to that one.
Well, basically, what is included in the manual is the Bayley-III and the PLS, because the PLS and the most recent version are very similar. I think financial issues probably came into play because it would be very difficult to get another 100 children, for example. So that is an issue. But I think looking at the Bayley-III and the comparison to the preschool language scale, and realizing that the Bayley-4 has such a high interrelatedness with the Bayley-III, maybe makes that less of an issue.
Great, thank you. And then this question, and I don't know if this is one you're able to answer, but so how long does it take now for parents to fill out the questionnaires, or all of those questions within the hands-on test? And do they also have to fill out the Vineland adaptive portion of the Bayley? I could start on that and then hand it over to you, Dr. Elwood, and just to say that there are some caregiver items which are embedded in the cognitive language and motor administration. And then there's the separate questionnaire, which is the social, emotional, and adaptive behaviour, and that's a subset. The adaptive behaviour piece is a subset of items from the Vineland. So it's not all the Vineland, it's a subset of 120 items, which is what the parents complete separately. But there are these additional questions that are embedded in the items, and I'll pass that on to Dr. Elwood to see if there's anything else to add on that.
Yeah, I don't know the exact time it takes the parent or the caregiver to complete those questionnaires, because I think there are a lot of variables that come into play once again. One of the variables, of course, will be parental education level. Another one would be the child's age, because it would take a much shorter time to complete the Vineland, for example, on a 12-month-old than it would on a 36-month-old. So, once again, I don't think I can answer that specifically because of the variability in terms of who's completing those questionnaires.
Yeah, and also to add, if I may, that they are being completed digitally, so sometimes people pause in completing those questionnaires. They might take a break and come back to it, so it is difficult to know exactly for sure, but rest assured it is much shorter than the previous version. So, if I could ask you another one, I'm concerned about parent or caregiver providing input. Sometimes they clearly over-report what a child can do. Will this impact the scores the child receives?
Well, we've looked at this, and we've looked in the literature as well. I've actually, with the Bayley Infant Neurodevelopmental Screener, had parents report whether the child could do any of the various items, and then we had blindly administered the items, not knowing what the parent said, and we had about a 0.80 agreement. So that started to give me some idea that this would work. Then, doing this in a very structured manner, not just, asking them off the top of your head about the questions, I think, once again, reduced the variability. I think the key issue was to look at the mean scores and see there was no difference between the parent completed and the actual administered items. I do agree that some parents are going to be biased, but you can see that. You can also test that by administering the item and asking the parent, or asking the parent first and then administering the item, and do that a couple times. You can get a pretty good idea if this person is exaggerating the child's skills or underestimating the child's skills. I do think as part of authentic assessment, which is something that I guess is conflicts with standardized norm reference assessment. They really like the parent to have report, parent to interact with the examiner, and so on. And I think there's definitely a strength to the whole testing procedure by incorporating it.
Excellent. Thank you very much. Right, we've got 4 minutes left, so I'll just try and take another couple. I'm just sort of running through the list. If we don't get to them all, I will try and get responses to you individually. We do get a report of all the questions we've not been able to answer, so we will try and get an individual response to you as well. So, so there's just another. I'm just trying to pick the ones that are. Is 16 days the earliest we can administer the Bayley-III? I'll pass that on to you.
I'm sorry, I didn't hear the question.
Sorry. Yeah, sorry, I wasn't very clear. Is 16 days still the earliest we can administer the Bayley-III?
The Bayley-4.
Bayley-4,
yes.
Sorry. I'm reading my error.
Yeah, the 16 days is the earliest. Well, you could administer it earlier, but you're not going to have no one prepared to.
Right, get you. Okay. Will there be any live training for the Bayley-4? I will answer that one just to let you know. We do have some training being developed, and we do have training options, and they're all listed on the website. We also have, so that will be both live options available and self-learning through digital online-based learning as well. So we have details of that on the website. And then let's just see. One more, and I'm just trying to pick ones that will be more relevant for you, because some of these I can respond to separately. Here's one. Will the Bayley-4 screener allow for prematurity adjustment?
Yes.
Excellent,
I think,
thank you.
Well, as I had mentioned before, that we're looking at adjustment for prematurity as a critical issue, and it is definitely necessary, depending on language, motor, or cognitive. The ages may actually exceed 2 years of age. So we're working on that now and hope to have that available shortly.
Excellent. Okay, so I think we've answered a good chunk, 22 questions there. There's still some that we haven't been able to get through, but I'm mindful of the time. I just want to remind people in this last minute of the instructions for those of you joining the session late, the instructions for receiving CE credits. You will have received the documents in the email that was sent to you at the top of the hour, these need to be completed and returned to Darlene Davis by no later than July 25th. You will, in that link, there's also a copy of as a handout of the presentation, so you can get the details from there as well. And there's Darlene's website, email address on the screen as well, should you have any questions. And for ASHA, you need to complete the participant form and the evaluation form and the attendance sheet if there's more than one person at your site. And then for AOTA, NASP, and APA, again, the attendance sheet if there's more than one person at your site, and the evaluation form, which needs to be sent to Darlene again before July 25th. On that note, as I said, we will work to get back to you with some of your questions individually. And thank you very much for attending today. And just to say, extend my thanks to Dr. Elwood for an excellent session and sharing some of these pearls of wisdom on the Bayley-4. So thank you very much, Dr. Elwood.
Well, thank you and folks for attending. I appreciate it.
Excellent. And we will sign off there. Thank you very much.
Yeah.